Thank you very much, Mr. Chairman, for the very kind introduction and very good evening, ladies and gentlemen. It is a privilege to be able to speak at this virtual menopause and women's health conference. I'd like to thank the organizers for this very kind invitation. Ladies and gentlemen, I'm given the task to speak on pregnancy after 45. Now, the medical term for this condition is known as very advanced maternal age. Now, despite being quite a well accepted terminology, I, for one, am not a very big fan of this term. Ladies and gentlemen, I would like to highlight a paper which was published in BMJ in 2018. It spoke about the importance of humanizing birth. And I think we are also well aware of the importance of respectful care. So I believe, for one, we should move away from the term of advanced maternal age. We should move away from the term of very advanced maternal age. I personally feel it is a discrimination against women. So I believe language matters. I believe as a fraternity, we need to better define women who are beyond the age of 45. Having established that, let's move on to the talk. The next 20 minutes, ladies and gentlemen, I would like to talk about four key areas. Introduction about women who are aged above 45, the significance of mothers who are aged above 45, the importance of fathers who are aged above 45. It is important to establish the age of the father as well. I'm not going to talk about the obstetrician's age in managing this couple, but ideally the obstetrician should also be an experience of age. And finally, I'm going to recommend my approach to the woman who's aged above 45 in pregnancy. So ladies and gentlemen, let's now talk about the introduction about mothers at the age of above 45. Now, what do we already know? The average age of mother of having a first childbirth in Malaysia, based on the 2018 data, is 27.8. There's been a significant shift worldwide. Women are now embarking on a pregnancy at a later age, and I believe this will shift further to a later age as we continue to progress. There's been a significant technology advancements in ART, and that wonderfully comprehends and that has contributed significantly to mothers at an advanced age to increase the age in mothers in embarking in a pregnancy as well. It is thus uncommon to have a mother who's beyond the age of 45 to embark on a pregnancy. But ladies and gentlemen, we do know for a fact that the medical and obstetric complications are higher. However, I must highlight the fact that there's a significant lack of science, significant lack of information and knowledge on how best to manage this cohort group of patients. And that is why we, for one, have a significant number of increase in obstetric interventions. I would like to highlight this wonderful paper, which was published by Fitzpatrick in 2016. It looked into UK's cohort of patients who were in advanced age. Now, what was interesting, in this cohort of patients, they had a significant number of mothers who were aged above 45. Some of them were also at the age of 61. I have managed numerous mothers above the age of 50. The mother who was oldest in my cohort was aged 58. So, ladies and gentlemen, this is a wonderful paper to review. Now, what are the facts based on this paper? Now, interestingly, 53% of those in this paper were nulliparous, and majority of those who were nullips had ART. 78% had assisted conception, and interestingly, 91% of them had an egg donor, 21% of them had a sperm donor. So, ladies and gentlemen, does the age of the egg matter, or does the age of mothers of the womb matters? I think it is important to differentiate this cohort, but these were the facts, and these were the cohort of groups who were evaluated in this trial. Interestingly, only 40% had one embryo transfer, 15% had more than 3 embryo transfers. Now, the number of patients with multiple pregnancies were 18%. A significant number of them were obese. 1 in 2 of them had an underlying medical condition. The mortality among this group was increased threefold. Yes, ladies and gentlemen, if you are pregnant at the age of above 45, your mortality is increased. Now let's take a look at the Malaysian data. And this is the most recent confidential inquiry report for MMR in Malaysia from 2017. If you take a look at mothers being aged above 45, the MMR is 155 per 100,000 live births. That is 7 times higher than the national average. So, ladies and gentlemen, if you're aged above 45, it is not threefold increase in Malaysia, but it is sevenfold increase. It is extremely significant. If you compare that with the Embrace report, the most recent Embrace report gives an MMR of 27 for those aged above 40. So I would like to highlight that 27 is actually 3 times higher in UK, but 155 is 7 times higher in Malaysia. Having established that, every single complication seems to be increased in pregnancy. If you're at advanced age, your risk of miscarriage can be as high as 53%. Risk of ectopic pregnancy can be as high as 6.9%. Multiple pregnancies, namely contributed by ART, is significantly high. The risk of a mother having trisomy 21 is 1 in 25 beyond 49 and 1 in 35 beyond 45. So it is significantly high. If you take a look at obstetric complications, it makes a lot of difference whether you conceive spontaneously or whether you had an assisted conception followed by a multiple pregnancies. Ladies and gentlemen, this combination of assisted conception and multiple pregnancies seems to be the worst combination ever. If you have a spontaneous conception, your risk of GDM is obviously high, cesarean section is high, ICU admissions are high. But if you conceive via ART, and if you have multiple pregnancies, then every single complication is increased, namely preeclampsia, PPH, and also preterm delivery. So this combination seems to be a lethal combination for those aged above 45. Now let's take a look between spontaneous conception and assisted conception. If you have an ART, your incidence of preeclampsia is increased tenfold. Your incidence of preterm delivery is of course increased. Your incidence of low birth weight is increased. So mothers who conceive spontaneously, who are elderly, fare better as compared to mothers who had assisted conceptions. Now this wonderful graph is by the Human Fertility and Embryo Act. I think they came with a policy of a single embryo transfer, but however, it is okay to have more than one embryo transfer for those aged above 40. But ladies and gentlemen, let us appreciate one fact. If a mother is at advanced age, if a mother is a primate, if she has got ART, and if she's got multiple pregnancies, she and her pregnancy will fare poorer as compared to a mother with a singleton pregnancy. So although it is legislatively okay to have 2 embryo transfer, I think we should really think about how to improve outcomes, and perhaps a policy of single embryo transfer may perhaps have a better obstetric outcome. So let's move on and compare between singleton as compared to multiple pregnancies. So it's not just ART, ladies and gentlemen, it is the number of pregnancies that you have. If you have multiple pregnancies, preterm delivery is increased, neonatal NICU admissions is increased, fetal growth restrictions is increased, cesarean sections is increased, preeclampsia is increased. So ladies and gentlemen, in this cohort, singleton pregnancies obviously fare better. So 2 risk factors, ladies and gentlemen, ART multiple pregnancies. These are the two things we should be trying to prevent. So moving forward, this is one wonderful paper that I would like to highlight. It is perhaps the one and only systematic review and meta-analysis looking into mothers at advanced age. Do you really think age is important? Yes, it is. The older you are, the higher the risk of obstetric complications. The older you are, the higher the risk of SGA, low birth weight, preterm deliveries, neonatal deaths, NICU admissions, UPGAR scores and neonatal acidosis, preeclampsias, abruptions, and GDM. Now, what was interesting, ladies and gentlemen, they further sub-analyzed into primates and multiples. So these risk factors seems to be even more significant if you embark at a later age in a first pregnancy. So, ladies and gentlemen, primates above 45 fare poorer as compared to multiples above 45. Now, the incidence of GDM is the same, but incidence of stillbirth, preeclampsias, and preterm births are higher among primates. So this is the third risk factor, apart from multiple pregnancies, apart from ARTs, are the primates. So having known that, ladies and gentlemen, I would like to highlight one important fact. It is often not just the age of the mother, but the age of the father also is equally important in obstetrics and has been a field which we have often neglected for many years. But I want to highlight this wonderful paper which was published 2 years ago, which talks about the forgotten father in obstetric medicine. Ladies and gentlemen, now we know that preeclampsia is actually not the mother to be entirely blamed, but it is actually a couple's disease because the father's health does have an effect on the baby's health and the obstetric outcome as well. And hence, there's increasingly more evidence on the importance of paternal health, which actually influences obstetrics outcomes. So, ladies and gentlemen, that brings to this wonderful theory called epigenetic integrity. Now, this simple concept talks about the association of sperm quality with pregnancy outcomes. The poorer the sperm quality, the higher the age of the father, the higher, the poorer the pregnancy outcomes. So, does paternal age affect as well? Yes. Just like maternal age of above 45, if the paternal is above age of 45, the pregnancy rates are lower. The miscarriages rates can be as high as 32%, irrespective of the age of the mother. The incidence of low birth weight, the incidence of stillbirth, the incidence of preterm deliveries are significantly increased. This can be explained by one simple theory which I explained earlier. It is called the epigenetic theory, or some people call it the epigenome reprogramming, where there is pre-meiotic damage causing birth defects, neuropsychiatric disorders, and malignancies. Ladies and gentlemen, there's also some recent studies showing the age of the father with the association of autism. And so paternal age is increasingly more important. Paternal health is essential in obstetrics as well. So, does genetic discrimination, genetic predisposition of the father influence pregnancy health? Yes. So maternal inheritance affects a lot of factors, but we also know that paternal inheritance affects the baby's genetics, affects the baby's epigenetics, affects placental function, affects germ cells, and affects microbiome as well. So the next time in your consultation clinic, if you have a pregnant mother, please do not forget to check on the paternal health as well. Paternal health, paternal well-being is extremely important. So having said that, having appreciated the risk of a mother who's above 45, having appreciated the importance of paternal age, how do we approach and manage these patients, ladies and gentlemen? Well, we do know that the mothers above 45, her maternal mortality is increased. But there are four other essential modifiable risk factors that reduces mortality. Apart from age, mothers who smoke, mothers who have got medical complications, mothers who have got poor antenatal care, and mothers who have got poor past obstetric outcomes are significant risk factors. So, to modify this, ladies and gentlemen, you need to optimize medical complications. If you think you need to see a mother 10 times in the antenatal care, perhaps you have to improve the antenatal care. You have to review them pre-pregnancy, review them antenatally, intrapartum and postpartum, and these are essential measures to reduce mortality. And similarly, you need to review the past obstetric outcomes. So, what is my advice with preconception care? Ladies and gentlemen, as an obstetrician, you can never tell a woman never to get pregnant. It is actually her own right. It is her fertility right. It should be her desire. You can only counsel, you can only advise. But despite knowing for a fact that age is an important contributor, not everyone in the same age group has got the same risk factors. Some are healthy at 45, some are unhealthy at 35. You need to stratify and see whether she's a healthy 45. Does she have got any medical comorbidities that can be optimized? Is she of normal BMI, knowing a fact that 1/5 of a mother at an advanced age will be obese? Should advise her to stop smoking. COVID vaccine, ladies and gentlemen, is ever so important now than ever before, especially for a woman who's an advanced age. The routine supplements has to be emphasized, folic acid. There's increasing evidence about the importance of vitamin D for every single pregnant mother, especially for a mother at advanced age. It is important to screen for diabetes, control her diabetes before embarking on a pregnancy. Now, an ECG is important just to look for left ventricular hypertrophy or for a silent MI. An important measure to assess her fitness will be a 6-minute walk test. If she can walk for 6 minutes, if she can maintain her heart rate and oxygen saturation, she is perhaps better as compared to someone who fails a 6-minute walk test. Mothers at an advanced age, you should screen for renal diseases. So once again, review her medications, review her allergies, review her past medical illness and her past obstetric history. Do not forget to review the paternal age, the paternal health. And although it is okay to have 2 embryo transfers, ladies and gentlemen, it is important to have a policy of a single embryo transfer. Our aim is for a singleton pregnancy. The outcomes are better. Please avoid multiple pregnancies as much as possible. How should you counsel a patient? Who should you be concerned of? You should concern if the mother is extremely obese. You should be concerned if the mother smokes or if the mother has got medical comorbidities. You should be concerned if the mother recently has had a malignancy. Malignancies at the age of 45 are usually breast, thyroid, colon, and ovarian cancers. You should be concerned if the mother had an untreated ischemic heart disease. Ladies and gentlemen, in the last 6 weeks, I had 2 mothers requiring angioplasties in pregnancy. Ischemic and coronary artery disease are the leading cause of cardiac deaths in this age group. It is important to screen for ischemic heart disease. Screen for diabetes, treat the diabetes, be concerned if she's got a poorly controlled diabetes. You should be extremely concerned if she's a primate, if she's conceived via IVF, and she had multiple pregnancies. Our aim is for a singleton pregnancies, is for a spontaneous conception if possible. Look into the past obstetric history. Be concerned if it's a new partner. That is a significant risk factor. And be concerned if the partner has got medical problems. So, ladies and gentlemen, how can you prevent stillbirth? Most of the stillbirths are UGR related. Most of the stillbirths are related to preterm deliveries and multiple pregnancies. So, if you can prevent multiple pregnancies, you can prevent stillbirth. And how can you otherwise prevent stillbirth? A policy of delivery by 39 weeks is recommended because now we do know that the risk of obstetric complications are increased in this cohort, especially for those beyond 39 weeks. And these are 4 key strategies on how you can prevent stillbirth. Having appreciated that, ladies and gentlemen, despite understanding the lack of science, here is my approach to manage a mother who's an advanced age. Number one, is this a spontaneous or an IVF pregnancy? Is she taking medications that are safe? Does she have got a significant medical condition that is not optimized? Is the father healthy? I would screen for renal function, send a urine PCR because proteinuria is a significant early indicator of renal disease. I would do an ECG. It should be consultant led, not led by a junior team. It should be managed by an experienced obstetrician. Date the pregnancy early, screen for diabetes. You can send an HbA1c or a random blood sugar. Does she have got an ischemic heart disease? Does she pass the 6-minute walk test? Does she need an echo? Does she need a stress echo? I would start aspirin. I would start folic acid high doses. I would think about vitamin D. Do not forget your VT risk assessment. The risk of preeclampsia is high. The risk of trisomy 21 is high, but you don't have to do an amniocentesis. A nuchal translucency, a non-invasive prenatal testing, uterine artery Dopplers are essential. Anomaly scans are important. Calcium supplements are important. If she's not diabetic, a universal screening for GDM is essential. There's an increased risk of IUGR, so she needs growth scans at 24, 28, 32, and 36. Aim to deliver her at 39 weeks. She does not always need a cesarean section, but you should actually monitor ECG and epidural intrapartum. Postnatally, talk about contraception, assess her VTE risk. Age is a significant risk, mental health, and she needs additional support in the postnatal period. Ladies and gentlemen, let's not forget about contraception, especially for women in this age group. FHRH has got a wonderful guidelines talking about contraception, especially for women in this cohort. I'm sure all of you all are well aware of these guidelines. So, ladies and gentlemen, my summary for this talk. I believe there's an area of scientific void, especially on how to best manage a mother at this advanced age. But, ladies and gentlemen, age is just a number. I believe do not forget paternal age. It takes two to tango. For a healthy pregnancy, both couples have to be healthy. As an obstetrician, you have to screen the mother, screen the father, and fetal screening. Perhaps pregnancy is the best time to have an opportunistic screening, especially about renal diseases, undiagnosed infections, coronary artery disease. Pre-pregnancy care is extremely important. You need to modify your obstetric risk. You need to optimize her medical health, especially her metabolic diseases and weight. It is important to prevent as much as possible multiple pregnancies. The outcomes of a multiple pregnancies following IVF is poor. Optimize health BMI, avoid stigmatizing, avoid unwarranted interventions, namely cesarean sections. But we really need to have better science on how best to manage a mother and couples at this age. So my take-home message, ladies and gentlemen, age alone is not a contraindication. I think we better need a better terminology than labeling them as a very advanced maternal age. I think it is discriminatory. We need to have a better term. I think we should not just manage the mother, but we should manage the couple. Unfortunately, we, the obstetric fraternity, as not as advanced, we are yet to understand on how best to manage the mothers at an advanced age. We need to have better evidence and better science on how best to reduce obstetric complications in this specific cohort. But as of today, ladies and gentlemen, the best way to manage these patients, best outcomes are from healthy couple, multiples rather than singletons, uncomplicated past obstetric histories, singleton pregnancies. They do far better than singleton pregnancies from IVF or IVF with multiple pregnancies. So, with that, ladies and gentlemen, thank you so much for your kind invitation. And I'll be more than happy to take your questions if there's any. Thank you so much.